Hello, dear colleagues. Can you hear me now? Okay. So, as you know, Crystal Vision Eye Clinic by Professor Igor Aznaurian organizing every week webinars on different topics in ophthalmology. And today we will talk about visual correction in kids. My name is Maya Dalalishvili. I am ophthalmologist, ophthalmic surgeon, and it's a great honor for me to speak before you today. Let me tell you about the main principles of optical correction in young kids. Let's start. So, refractive errors are a common eye condition that occurs when the eye shape prevents light from focusing directly on the back of the eye, resulting in blurry vision, among other symptoms. The main types of refractive errors are myopia, hyperopia, and astigmatism. Refractive errors can generate different symptoms according on their nature and severity, and these symptoms include blurred or disrupted vision, eye strain and fatigue, squinting, headache, eye irritation, sensitivity to light, and so on. There are certain conditions for the suitability for the method of correction of this eye problem. The most common methods used to correct this error are glasses, different types of contact lenses, and refractive surgery. Ametropia correction in children requires special considerations. The best corrected visual acuity is not the only goal of prescribing optical correction in children. Ophthalmologists must carefully consider to provide the focused retinal image and to maintain an optimal balance between accommodation and convergence when prescribing correction. The prevalence of magnitude of hyperopia is greatest during early childhood, decreasing in the first decade of life through the process of emmetropization. Most infants have mild hyperopia, with only a small group of cases having moderate or high hyperopia. However, infants with high hyperopia are more likely to remain significantly hyperopic throughout childhood, and in young children with significant hyperopic astigmatism, especially against the rule astigmatism, the reduction in hyperopia is less than those without significant astigmatism. Some children who do not go through the process of emmetropization remain significantly hyperopic and have an increased risk for developing strabismus and amblyopia. Uncorrected hyperopia may be the cause of different conditions like constant or intermittent blurred vision, amblyopia, strabismus, astigmatism, accommodative and binocular dysfunction, and of course red or tearing eyes. Hyperopia is the most common refractive error in children. In the multi-ethnic pediatric ophthalmology study, the prevalence of 3 diopters hyperopia among non-Hispanic white children was found to be 13% among 3-year-olds, 7% among 4 years old, and 11% among 5-year-olds. Even among preschool-aged Asian children, there was a high prevalence of 3 diopters hyperopia, from 5 to 6%, compared to the prevalence of myopia. And about 20% of children with hyperopia develop esotropia with an angle of deviation from 20 to 40 prismatic diopters at the age of 2 or 3 years. According to the latest guidelines from the American Academy of Ophthalmology, there are a number of factors to consider when deciding whether to prescribe spectacle correction for children with moderate hyperopia without esotropia or decreased visual acuity. The Academy recommends prescribing optical correction for children from 2 to 3 years of age with isometropia and hyperopia more than 4.5 dioptries, regardless of whether they have significant esotropia. However, it's important to note that this recommendation is based on consensus and not on analysis of published data. These values were developed by consensus and are based on professional experience and clinical impression. The exact values are unknown and may vary among age groups. They are provided as general guidelines that should be tailored to the individual child. Specific recommendations for older children are not provided because optical correction is determined by the degree of refractive error, visual acuity, and visual symptoms. Here's the data accepted in Russia for hyperopia norms in children depending on age. As we can see, no differences were noted depending on the presence or absence of strabismus. There are no generally accepted standards for hyperopic refraction norms, and that's why the issue of prescribing glasses to children with hyperopia and esotropia is very important and requires great attention. The precise correction of childhood hyperopia is more difficult than that of myopia. Children with significant hyperopia are more visually impaired than their myopic peers who can see clearly at near distance. The close association between childhood hyperopia, amblyopia, and strabismus makes hyperopia a greater risk factor than myopia. Optical correction should be based on both static and cycloplegic retinoscopy, accommodative and binocular assessment, accommodative convergence or accommodation ratio, age, degree of symptoms, amount of hyperopia, visual acuity, and the correction modified to facilitate binocularity and compliance. The goals of treatment are to reduce accommodative demand and to provide clear, comfortable vision and normal binocularity. Young children with low to moderate hyperopia generally require no treatment unless they do not have strabismus, amblyopia, or other significant vision problems. Next, we will discuss the topic of prescribing optical correction for children with hyperopia and esotropia in more detail. Studies have shown that in children with esotropia, the process of emmetropization occurs less frequently than in children with similar hypermetropic refractive errors but without esotropia. A group of scientists in 1995 suggested that wearing glasses with full hypermetropic correction in childhood interferes with the process of emmetropization. Also in their studies, they came to the conclusion that an increase in the degree of hypermetropic refraction is directly proportional to the amount of optically corrected esotropia, while the normal process of emmetropization is disrupted. The higher the degree of hyperopia, the worse the development of accommodation and consequently the risk of increased convergence and weakening of divergence increases. The mechanism of accommodative esotropia involves three factors. It's uncorrected hyperopia, accommodative convergence, and profusional divergence. Play the video, please. Okay, so if a patient's fusional divergence is poor and easily overcome, esotropia occurs. Mild fusional divergence may occur if the amplitude of fusional divergence are small. Patients with significant anisometropia are also at risk of developing refractive accommodative esotropia even in the presence of lower degrees of hyperopia. The mainstay of treatment for refractive accommodative esotropia is vision correction with glasses. According to research, wearing glasses helps to restore the correct position of the eyes, prevent amblyopia, and maintain stereopsis in children with accommodative esotropia, while full correction prevents the process of emmetropization. Early correction of hyperopia reduces accommodative esotropia by at least 50%. Correct optical correction is more likely to result in emmetropization in accommodative esotropes than in partially accommodative esotropia. The magnitude of undercorrection correlates with the change in hyperopic refractive errors in early and late childhood, and complete correction of hyperopia and esotropia independently of each other can prevent the reduction in the degree of refractive error and axial growth of the eye. Full hyperopic correction based on cycloplegic refraction is prescribed initially. This applies to both juvenile and infantile forms of refractive accommodative esotropia. The initiation of treatment requires some urgency, since delay may lead to loss of fusion, development of amblyopia, and loss of stereopsis. In 1995, a group of scientists suggested that wearing glasses with full hyperopic correction in childhood interferes with the process of emmetropization, and this may be due to the lack of myopic shift in patients prescribed glasses based on cycloplegic refraction. On this slide, we can clearly see the treatment tactics for patients with hyperopia and esotropia. In case of stable refraction value for 2 years or more in children over 5 years old, laser correction of hyperopia can be performed to eliminate the accommodative component of strabismus. Ophthalmological examination before laser correction includes determination of visual acuity without and with correction, manifest and cycloplegic refraction, keratometry, keratotopography, and so on. There is a list of studies conducted on the topic of refractive surgery in children with an accommodative component of strabismus. Professor Dvali, in his work Features of LASIK in Children with Hyperopia, came to the following conclusions. The angle of deviation decreases in case of partially accommodative esotropia or disappears at all in case of accommodative esotropia. The type of vision changed from monocular to binocular in period from 3 to 6 months after LASIK. LASIK eliminates the accommodative component of strabismus, achieving stabilization of visual acuity and reduction of elimination of amblyopia. The angle of deviation after the LASIK procedure changes in the same way as when wearing optimal correction of glasses. Positive dynamics are observed in cases with a residual angle of deviation of the eyes. And LASIK is an effective and safe procedure for the treatment of hyperopic anisometropic amblyopia leading to esotropia. So one more time, let's talk about the main principles of visual correction in kids with hyperopia and esotropia. First of all, the use of glasses to correct refractive errors is the main method of treatment. Patients with accommodative esotropia experience a constant decrease in refractive error over time when wearing optical correction. Excimer laser correction in hyperopia and hyperopic astigmatism in children and adolescents allows to correct refractive errors, correct accommodative strabismus, improve visual functions of eyes with amblyopia, and improve binocular vision. Early treatment results in a higher percentage of positive outcomes, like orthophoria, stereopsis, emmetropia. Now let's talk about myopia. Myopia is a significant prevalent disease in children with increasing rates of progression. With over 80 million reported myopic children worldwide, there are considerable socioeconomic and public health concerns. The prevalence of myopia is less than 5% in the 5-year-old population, increasing to 20 to 25% in teenagers and from 25 to 35% in adults. Children with refractive errors in the range of emmetropia to 0.5 dioptries are more likely to become myopic than the same age children who have hyperopia more than 0.5 dioptries. The risk for myopia is higher in children who have against the rule astigmatism. A substantial amount of research has been done to determine the etiology of myopia, the risk factors associated with myopia, techniques to prevent myopia, and ways to treat myopia. According to the work of scientists in 2016, by 2050 there will be an estimated 5 billion people with myopia. It's about 50% of the total population, of which 1 billion will have high myopia. It's about 10%. In 2000, the prevalence of myopia did not exceed 50% in any region, but by 2050 the prevalence will be more than 50% in 57% of countries if current trends continue. Moreover, high myopia is associated with potentially blinding complications such as glaucoma, retinal detachment, and myopic macular degeneration. The risk of developing myopic maculopathy increases with myopia progression by 1 dioptries. Main risk factors of myopia are genetic predisposition, weakening of accommodation, weakening of the sclera, insufficient physical development, endocrine changes in the body during puberty, not enough time spent outdoors, and early and intense visual loads at close distance. For example, use of computers and gadgets. There are several studies that have reported urbanization as a potential determinant of physiologic myopia. Many studies that have shown an association between increased myopia in urban areas as compared to rural areas are confounded by variables such as level of education, IQ, socioeconomic status, near-related activities, and outdoor exposure. Cycloplegic refractions are necessary. Generally, full refractive error, including cylinder, should be corrected. Young children tolerate cylinder well. A careful subjective refraction should be performed to determine the lowest minus lens power that achieves the best visual acuity. In cases of large exophoria or intermittent exotropia, a prescription for full-time wear of the full myopia correction is suitable. Contact lenses may be an alternative to expand the visual field, provide a larger retinal image size, and reduce the possibility of induced prismatic imbalance from the tilt of the spectacle frame. Myopic contact lenses require more accommodation than spectacle lenses, resulting in the risk of near-point blur and eye strain in high myopia. Contact lenses result in less anisoconia and anisometropia. Some ophthalmologists undercorrect myopia, and others may even use bifocals with or without atropine on the theory that prolonged accommodation hastens the development of myopia. However, this theory is controversial. Moreover, according to studies comparing undercorrection and full correction with monofocal glosses, the progression of myopia is higher in the undercorrection group, according to cycloplegic data, of course. The retina has a central peripheral mechanism for adjusting axial growth of the eye that is sensitive to local retinal image contrast and hence retinal image defocus. An increase in the area of retinal defocus increases excitation of the periphery of the retina relative to the center. This excitation causes an increase in the rate of release of neuromodulators by amacrine cells that are sensitive to changes in peripheral constant. So this in turn causes an increase in the synthesis of protoglycans, which strengthen the structural integrity of the sclera. So here we have a little video. Let's play it, please.
With standard single vision lenses, the central zone works fine, but the periphery of the lens often projects the image behind the visual area. This can result in a signal to the eye to elongate, which increases the progression of myopia. So the Zeiss MyoVision Pro lens's active zone in the periphery corrects this defocus and in consequence can help reducing myopia.
So, when wearing monofocal glosses, the central part of the image falls exactly in the fovea, but on the periphery of the retina, it's projected behind the retina. This is called hyperopic defocus. This condition stimulates the growth of the eye in lens and accordingly leads to the progression of myopia. Modern correction methods have a certain design that takes into account the risk factor of hyperopic defocus. The image on the periphery is projected in front of the retina, as in myopia, creating myopic defocus. Thus, there is no signal to increase the axial length of the eye, and refractogenesis is inhibited. Correction methods that create peripheral myopic defocus on the retina include spectacle lenses with special technology, DIMS and HALT, soft contact lenses with peripheral defocus, and orthokeratology lenses. The technology was developed in 2014 in collaboration with Hong Kong Polytechnic University. The alternation of focus and defocus zones ensures clear vision and at the same time helps to slow down the development of myopia. 2-year randomized controlled clinical trial and 3-year follow-up clinical study data have been published, and 6-year data has been reported, making this the longest running study on spectacle lenses for myopia management. The 2-year data for MyoSmart showed that there was an average 59% myopia control effect in the cycloplegic spherical equivalent refraction and 60% in axial length. 6-year data shows that this effect is sustained, and early indications also suggest there is no rebound effect after cessation of MyoSmart and uptake of single vision lenses. let's talk about DIMS technology. A central zone 9.4 millimeters in diameter that provides full refractive correction in the form of a single vision lens surface. An annular multiple focal zone of 33 millimeter in diameter, comprising of 396 segments, and surrounds the central zone. Each segment in the treatment zone is 1.03 millimeter in diameter and has a relative positive power of plus 3.5 dioptries. These segments are arranged in a honeycomb array, which allows for some distance correction in between the segments. The treatment zone is designed to introduce myopic defocus constantly when viewing both distant and near objects. Now let's talk about lenses with HALT technology, known as Stellest, a Essilor company. The HALT high aspherical lenslet target technology is made of a constellation of 1.021 invisible lenslets. This constellation creates a signal in front of the retina that acts as a shield against eye elongation and therefore myopia progression. As a result of numerous studies, was proved that Stellest lenses slow down myopia progression by 67% on average compared to single vision lenses when worn 12 hours a day. The eye growth of 9 out of 10 children wearing Stellest lenses was similar to or slower than non-myopic children. 2 out of 3 children who wore Stellest lenses had a stable need for vision correction after the first year. HALT technology, which consists of 11 rings of 10-21 adjacent and aspherical lenses, central empty zone about 9 millimeters. Inside one ring there are lenses of the same geometry, but the lenses from each ring have different geometry. There are gaps between the rings, and highly aspherical lenses create a volume of myopic defocus. Another method of correction with peripheral defocus is orthokeratology lenses. Randomized clinical trials of orthokeratology myopia control have demonstrated significantly slower axial lengthening in children wearing orthokeratology lenses than in children wearing monofocal glasses. Orthokeratology results in a reduction in myopia progression by approximately 14%. With orthokeratology lenses, the patient wears reverse geometry contact lenses at night to temporarily flatten the cornea and provide clear vision during the day without glasses or contact lenses. Myopia reduction up to -6 dioptries is achieved by flattening the epithelium of the central cornea and mid-periphery and thickening of the stroma. Orthokeratology contact lenses can be used to correct central refractive error while leaving peripheral myopic defocus, which may serve as a putative signal to slow myopia progression. The big advantage of night lenses is that the patient can see clearly both with and without the lenses. Indications for orthokeratology lenses prescription is correction of refractive errors, progressive myopia in children, myopia from -1 to -6 dioptries above custom design, compound myopic astigmatism. Adult patients with myopia who, due to subjective and objective circumstances, cannot undergo refractive surgery, and patients with myopia who, for professional reasons, cannot wear glasses and contact lenses. For example, athletes, drivers, and so on. The most common strict contraindication for orthokeratology lenses is past and present corneal diseases, keratitis, severe dry eye syndrome, taking retinoid drugs, diabetes, hormonal therapy, pregnancy, systemic diseases in acute phase, and so on. So far, these are the only daily contact lenses that prevent the progression of the disease in patients under 18 years of age. They are recognized as such by the FDA. The positive effect has been proven experimentally in an experiment that the manufacturer conducted over 3 years. Children with myopia were offered to correct their vision with MiSight one-day contact lenses. In 75% of cases, the progression of the disease slowed down by 13 to 60%. More than 90% of children did not feel the products on their eyes and did not experience difficulties when putting them on or taking them off. The MiSight one-day lens is a defocus lens. It has two alternating optical zones, they create myopic defocus in the field of 30-50 degrees from the central zone, which slows down the progression of myopia by 59%. Once again, let's us to sum up principles of visual correction in kids with myopia. First of all, full refractive error, including cylinder, should be corrected due to cycloplegic values. Undercorrection must not be prescribed to children with myopia. It's very important. Methods of visual correction with peripheral defocus help to slow down the progression of myopia and to achieve early stabilizing. That's all for today. Thank you for your attention. If you will have any questions, please write them in the chat, and I will answer on them in the chat. And I want to tell you that on the next week, Professor Agnes Oganisyan will talk about Descemet's membrane endothelial keratoplasty. He's a great professor. He's a great specialist, and I think that you should be on this webinar. We will wait for you. Any questions? Okay, colleagues, I hope that it was interesting, and that your morning were perfect. So thank you and goodbye. And if you will have any question, you can write us, for example, on Instagram. We will ask you. We will answer you. Thank you very much. Goodbye.